Okay, so now we're going to step into the conversion. Dr. Sharafi has set us up nicely. So if we look in the mouth here, and get the tongue out of the way, you can see basically that we don't have too much of the Vorby field. You can appreciate how flat everything is all the way around. I mean, he's done a wonderful job setting me up for success here. So I'm very happy. Now, one of the things, if the patient is basically asleep like this, the tongue is all over the place. And so you'll notice if I put the denture in here, and I'm not too careful, denture goes in, patient closed down, notice the tongue. You see that thing? Mm-hmm. That's not going to allow me to get those teeth in there very easily. So you really have to kind of push the tongue out of the way, kind of have the teeth sort of get in there, and then manipulate it into place. So that tongue oftentimes, like I said, is going to be a little bit of a problem. So you kind of have to get it out of the way so that you can see that the teeth are going to be in contact with each other. Something like that. Okay? So I have the denture seated. We're basically on the palate. If we look in here, massive tongue in the way, but what I'll do is take a intraoral mirror here, stick it in the back, and it's hard to tell, but we're basically just making sure that the soft palate is seated here so that we don't have any huge amount of space and the denture isn't binding. If the denture was binding or rocking and moving all around, then I would try and locate where that spot is and maybe hand it to my lab tech. So like if you look at this, if my flange is extended, sometimes I won't be able to get it seated down, especially if you have a big piece of bone here, like on the buttress of the maxilla or something, and you just can't get it seated. You have to get that trimmed up appropriately. The reason I do it this way is the patient's already asleep, and it's just easy enough for us to kind of do what we need to do. He's kind of going right into that position. If you look at the teeth in terms of the contact points, they got a nice
Pull
sort
the
of...
lower lip down just a little bit.
Okay, anyway, I'll show you right now on the denture here. You can see where basically we have the indentations. If I'm looking down those angles, they all look very good in terms of being inside the denture. So I'm going to hand this to the laboratory, and I'm going to let them go ahead and remove those holes. And in a case where I'm concerned about the position, I might tell them just to make a small pilot hole. In this case, we're going right to it. So now what we're going to do is we're going to remove our healing caps. And when I do this, I'm going to keep basically one hand with my fingers on the healing cap. Yeah. Yeah, that's a great question. So I always have my lab create a traditional immediate denture. I do not want bone reduction inside of that, because if we don't load, then you actually have to trough that stuff out, and it's a real bear to do. Also, it's very easy to fill up that space. It's not so easy if you don't do adequate bone reduction to actually get the cylinders to be in the right position. So I always want more space in there so that I have areas to work with. It makes it so much easier for me once I keep the denture to then evaluate where those screw access holes are going to be. Okay, so we've taken those off and we're putting our impression copings on. Well, probably better if we can kind of get this thing in here. Hold it like that while we're doing it. There you go.
And so all the docs were here for the surgery part, but with the restorative part, they all left.
Okay. So now we have those seated, and what I'm going to do is just basically check with the perio prober and explorer. I'm going down once again to make sure that we're seated all the way, and I can feel no gap in the junction here. My one on the left here feels like it's a little bit high or something's going on, so I'm going to try and re-screw it in place. And that would feel good. So I'm ready to make my impression now.
Okay.
And the first thing we're going to do is take a 2x2 gauze and we're going to wipe everything off to make sure it's nice and dry. Okay.
Put around the caps and I'll load the tray.
Okay. So what we're going to do is just kind of squirt material around these caps to capture as much as we possibly can. And we'll insert this in the mouth. And now, just like any other closed tray, we will sit here and wait. So we're going to take this off now. Should be set. So here's how our impression looks. Oops. Here's how our impression looks. And you want to make sure that each one of these little areas is basically not distorted. So we're looking pretty good right now.
You didn't get any sutures either, right?
Nope, we're good. So basically we're going to hand that to our laboratory. And then I'm going to look in the mouth. And one of the things I can do is a quick and dirty way for me to check where those access holes are in my new denture that we created. If you hold that for me. So here's the denture that they've provided me with. They've drilled the holes. And one of the things I want to do is check these holes and see are they in the right position. So what I'm going to do is I'll place the denture into the mouth. And I'm going to look and I'm going to see if these holes actually match up. So if you look here, I can see, oops,
Yeah, there you go. Perfect.
yeah, I can see where some of them might be binding on the actual acrylic and are not actually being able to sort of freely move this. So then what I'm going to do is I'll take a Sharpie, and basically this is our surgical Sharpie we call it, and I'm going to mark basically where we need to adjust to open up the hole. So I'm marking. Yes. Yeah, so the lower is more difficult, and we can talk about that basically once we get done with this one and while the lab process is occurring. But the lower you kind of need to float it into place, and you need to have it at the correct vertical while you're making these marks. Because what happens is if your vertical is too open, then as you close it down to the correct vertical, your holes need to shift forward, if that makes sense. So every time you open, basically the holes shift back. Every time you close, the holes shift forward. So if you're not in the right vertical, then oftentimes when you go to pick it up, you're going to have problems in terms of orientation. So now we're going to take out our impression coping. So we're going to unscrew our impression coping. And the impression coping serves to help us with the orientation of the access holes that we need. So here is our temporary cylinder, our titanium coping, I suppose they call it. And if you look at this, the screw is already preloaded, so I can carry it into the mouth like this. So if I have my hands like this, it's all one unit, all one piece, it's not falling anywhere, so I can deliver this directly into the mouth. So I'll take it here, and what I'm doing is basically just orienting it with my left hand, and with my right hand I'm going to screw it into place. So sometimes it's very difficult to get back there. Right now we have a lot of space, so we're good to go. Okay? Now, the rubber dam basically is to prevent material from flowing into the flap. So that's why we're doing this portion of it.
I want to show that we keep it on double-sided tape.
Typically what we do is we'll have this on double-sided tape, so it's very easy for us to kind of grab whichever one we need. The back pieces have a larger rubber dam, and the front ones usually have a smaller rubber dam because they're more close together. So our copings are now in place. And if I look at the mouth now, you can hold on again. If I have the patient kind of close down, I can see that my copings are actually not even going to touch. So they're not going to get in the way of occlusion, which is nice. So I have lots of space here to work with. So what we're going to do now is we are going to try our denture back in. So we have holes that have been opened up a little bit more. I'm going to try this in the mouth. And when I put it in here, now you'll notice I can rotate this around a little bit more. So if I can rotate it around and I have clearance, that gives me the opportunity, if I don't like my midline, to shift it slightly or move it around. So now what I'm going to do is I'm going to take the patient, I'm going to clear the tongue, because it's massive and in the way. And what I'm going to do, got it. Yeah. Okay. So now I can see that I can seat my denture, that he's got contact in the areas that we're looking to achieve contact. And sometimes I'll use basically like a jaw relation record that was previously fabricated. In a case like this, if it's fairly easy for me to get everything oriented where I need it to, I oftentimes won't use it because it just sort of gets in the way for me. So basically here we are. I can see them all the way down. And now when I'm here, I'm going to check basically our fight stick that we have. So if you kind of look at the position of where he was and you kind of look here, we're pretty darn close. Now in his case, I think Dr. Sharafi kind of had him closed a little bit more, but since the palate is seated, I know I'm pretty much in a good position here. So I'm close. I'm happy with where we are.
What does different sound mean?
Yeah, exactly. It's much more important with the lower. So now I'm sort of checking the incisal edge position. Kind of like what we have there. We're looking pretty good. Open. I'm saying open, the guys are sleeping. That's pretty funny. Okay. So now we're going to close them down one more time. I'm sort of orienting those teeth, making sure when he bites down, I like where the position of everything is. Yeah, exactly. And you can feel it when he's seated. His condyles are seated and we're basically going straight up and down. So now it's a matter of making sure we're going straight up and down right into the position that we want for our bite. Okay. So I'm pretty happy with where we are. Now I'm going to hold basically the upper teeth with my left hand. I'm going to open them up. And now I'm looking at all of the cylinders to verify that we're clear 100%. And I'll try and get one that we can see really well. We have a little bit of binding, so I'm going to hand this back to the lab. I don't know if you can see the binding. Yeah, right there. Got it? Yeah, right there. Yeah, so that area needs to go a little bit. So I'm going to hand that back to the lab.
What about this? No, we're good.
No, we're good. We're clear everywhere else. It's just that right here. No, over here. It's good.
I'll get it.
Take a seat. Okay. So I hand it back to my lab. We're going to make our final sort of tweaks here. What we're going to do is put some Teflon tape into the access hole. So plumber's tape, Teflon tape. I'll take this stuff to kind of wrap it up. And I'll show you over here. Hopefully we get a clear view. You can sort of see how it's sticking out. It's going to stick out quite a bit. You take your driver and you kind of smash it down in there. And it smashes quite a bit when you put it down there. That's it. Sometimes we'll put wax just on the top like a tiny bit. Yep. Now if you're doing this, you don't even have to pack it all the way down into the hole. You can leave a little bit out if you want. So we're going to do this for each of our cylinders here. Now they also have a different version of this tape. They have a yellow tape that's a little bit thicker, easier to pack. Our laboratory unfortunately forgot it for our big fail here.
You want the one?
No, I don't need any left. So I'm going to try the denture back in one more time. Make sure I can move it around. I'm comfortable with where that is. That's great. I'm going to have the patient close down and sort of stick their tongue. Well, typically what I'll do is, let's say the cylinder is hitting the bottom tooth. What I'll do is I'll have the patient close down basically to the position where I like the teeth, verify that the vertical is correct, and I'll use that as a stop if I have to. So hopefully that's in the posterior where we'll have a little bit less room there, but ideally you don't have that issue. So I don't want to cut it off. So for instance, the denture might be seating like this. If it's higher and it's not actually sitting on the palate, that's okay so long as my vertical is in the right spot. And typically that'll happen if you've done a lot of bone reduction. That can occur.
This is because you had to add so much more acrylic.
Yeah, so then you just backfill with acrylic, but that's what you're
Which is a
to
good
do
thing.
anyway.
Very good.
Okay, good. So I'm playing around with this so much because I really want to try and get that midline on. I'm really trying to figure out where that occlusal plane needs to go. And in his case, he has such poor palatal architecture. It's really hard to tell where that would be just with the palate. So I'm kind of looking around at it and sort of looking at the midline here, trying to assess where I want to go.
Are you showing us the cycle?
Yeah, it's fine. Yeah, he shows way more than he used to.
Yeah.
Okay. Yeah.
You can be both us if you want.
Okay.
That's nice.
Good, yeah. So I have an idea of where I want to pick it up now. And so now I'm going to hand it to my lab. And they're going to put their adhesive on there. So this is the 3M hard to cure. They're going to put the adhesive, which is I think the A portion. The B portion I think is the actual acrylic stuff. So I'm just drying off my cylinders, making sure there's nothing in the way that's going to get in between me, the cylinders, and then the material itself. Okay, so I'm just going to kind of pat everything down here to try and get it close to the ridge. And just make sure that I feel like this condyle is seated and that he's repeatedly going into this position. That feels good. Notice I'm just doing a chin point guidance here. I'm not getting all crazy with like a bimanual manipulation. As long as it feels repeatable and he's not falling out of his joint. Sometimes when they're asleep, you're going to pull left, right, and it doesn't actually get back into a seated position. So, but he's actually pretty good. But usually what I'll do in those cases, I'm not going to go crazy trying to adjust the occlusion at the time of delivery. Oftentimes I'll see that patient maybe, I don't know, 7 days later, 6 days later, whatever, so that they are a little bit more settled in terms of their recovery, but enough that I can adjust some of the occlusion at that time. So I don't spend a whole lot of time adjusting occlusion at this point. Most of the time we don't need to, but if we did, I'm not going to adjust it too much at this point because one is once they get out of this, their jaw joint position may change, and two, you just don't want to keep them going through surgical stuff if you don't have to heal. Good. So now what we're going to do, we can kind of hold them open. I'm going to syringe the material basically right around these little set cylinders, and we try and put it down there as sort of as far as we can. Some people say just past the top, and that's fine, but I find I can get a fairly consistent fill without any void when I'm doing this, especially if Dr. Shirafi has sealed everything up as nicely as he has. You notice we don't have any blood or anything like that seeping up through those cylinder areas, which is awesome. That means we're going to get good contact and good bonding. So that's great.
So since you painted it with monomer, right? You just painted the whole thing.
No, it's the bonder.
There's a bonder, like an adhesive.
There's the monomer and polymer.
Oh, right. Okay. So you
You
bonded
need a little more.
Need a more?
Actually, you know what? That's okay, I can use this.
Sure.
Yeah.
Yeah.
So now what I'm doing is taking a little brush, and I'm just trying to help out my lab by kind of putting this material so that it's a little easier for them to clean up. Not as much bulk.
Lift it.
Okay.
Maybe.
So now what we're going to do is I'm going to move the patient's tongue out of the way a little bit again. And once again, now I have him biting into these teeth. And I'm looking at the midline saying, it looks like it's shifted a little bit to the left. So I'm going to kind of orient that as best I can to the midline position of where I want it to be. And I'm holding it in place, making sure I have basically contact bilaterally as much as is possible. And now I'm going to kind of hold him there. So my left hand is holding the denture. My right hand is holding his jaw. And now basically what I'm trying to do is just hinge him into the same position over and over, making sure that when he closes, he's closing as close to CR as is possible. Now, am I in CR? I don't know. But I'm in a repeatable position that I know he can go into every time. And because his joint is healthy, as long as I'm within the ballpark of CR, we'll be fine. And then I can adjust occlusion later on to make sure that we're right there.
Do you want to mention one of the advantages of this material? It gives you 6 minutes to kind of work all of this out.
Yeah,
before
so the advantage of the material is you do have basically 4 solid minutes of working time. So when I'm doing this, notice I'm going to open him up, and I'm going to look at the cylinders. You hold his jaw down. And what I'm doing now is I just want to clear any acrylic that got around or into my cylinders, make sure everything's clean. It looks pretty clean. And you want to clean anything that's on the side because then you might get something caught up in there. So now we're doing the same drill again. Got to get his tongue out of there. Good. So we'll kind of measure his vertical again. And once again, it's extremely hard if you basically have, nasal intubation to actually get a real good view. But we're kind of in the right position, so I'm pretty happy with where we are. Now at this point, basically you're going to hold everything in there, and you want to hold it really nice and tight. You want everything nice and snug, because if the patient actually is awake, what will happen is they're going to move or turn or do something, and so then basically you lose all the stuff that you just worked for. So I'm going to open him one more time, let him close. Good. Good.
Three minutes has gone by, you're just under 5.
Okay. Now, once again, if this patient had a difficult bite, or there was a reason to basically use the jaw relation record, I would do that at this time. But sometimes the record gets in the way, especially if you've added temp cylinders, or if you have acrylic going around, sometimes it can become a real mess. So that's why a lot of times if it's pretty simple like this, and you can get an MIP that kind of locks in, then that's where we're going to stay. So I'm not 100% happy with his midline. We're in the ballpark and pretty close, but sometimes basically getting him into a better occlusion is more important.
3, 2, 1, we're good.
Okay. Now we open him up, and we're going to clear out the cylinders. I'm just going to kind of take a look. Right now he might be kind of binding somewhere here, so we might end up closing posteriorly. Yeah, over on this left side. When it kind of comes into closure.
Yeah, I'm not judging
We're
it.
going to trim from the
Yeah, we're going to trim back here anyway. And get him to seat down will be pretty easy. Once it's all done, now we're going to just clear out the hole. My assistant is doing a wonderful job.
Polish it, high shine it, just like we would a denture, and we're ready to go.
And then we get the body impression now, index it, or
No,
no?
because chances are.
And once it comes out, notice I have 2 fingers on my screw and 2 fingers on my driver every time. I don't want to drop something down there. Now at this point,
I go through the whole video and that I'm watching and go through it?
And that's final one here. Once this comes out, we always want to check for our laboratory that everything has been picked up appropriately. Now this will just kind of pop out of his mouth here.
And then because it's not a true
Kind of just want to
off completely one.
Just the way I mounted it.
Yeah. Like you had.
Yeah, there we go.
Okay, look at that.
So here's what it looks like. We basically picked everything up. And actually, technically, you'll see the contours of the tissue here. So you could put your cylinders direct, or your analogs directly in here, and pour up the basically model inside of this. And so that's what I'm doing a lot of the time. If you've captured basically enough to have that, then you can do this. So what we'll do now is just take like a whatever kind of instrument, and we're just making sure that we have enough around each cylinder. You'll notice there's a void here. That void's fine so long as the cylinder is stable and held in place, because the lab's going to fill up all those voids. So we're set, we're ready to go. We give it to our lab. So in the meantime, we will put healing caps back in place, and then our laboratory is going to take over for us.
No, I understand yet.
Your turn.
My turn? Forza Italia. Let's go.
Vive la France.
Vive la France. Vive les Gaulois.
That's a big one. You could just box that denture, pour it off some stone.
So if we kind of clean
You want
everything
to
up,
drive
we'll be able to see it a little bit better. And also, you can see that these are nice and clear and open. If you get this back and it actually has acrylic that goes around this, oftentimes it won't seep.
Right.
Yeah. All right, Jimmy, here we go. Go ahead and open. And you'll feel a little pressure here. There you go. Cool. Typically, I'll leave the screw inside the prosthesis. Screw in place. Jimmy is a student of the game. I love it, Jimmy. Okay.
Good job. Just move it right up there.
Yeah, I've never seen a sinus lift before. That was really cool.
You ever see that? Sinus can turn into disasters.
Okay, so if you get to this point and it's not screwing in passively, then maybe something's wrong. Right now it's very easy. You're over a screw going in, but one of the things that can occur is when you go into this level, when you go to place the prosthesis in the mouth, you either, you can have a lot of soft tissue that actually gets in the way. So when you seat your prosthesis, if your surgeon has not actually created a level platform for you, it can be a real problem. Jimmy's well aware of that. He's encountered that before. Okay. So basically when we close him down, go ahead and just close gently, Jimmy. So basically where we want to be, there's a little piece of acrylic over here on this one tooth that's kind of holding him up. So once I relieve that, he'll sit all the way down. But I'm not going to do it right now. I'm going to do it basically on Monday. Yeah. Let's get him out of here and get him comfy. Because he'll be just fine. So in general, like I said, I don't do a lot of adjustment right now. Because I want the patient to be comfortable and be able to get out of here.
The food's on there right now, too.
That's right.
That's
So Jimmy,
good on $30 a pound.
right. So we're doing pretty well here.
I know.
All right. So what we're going to do now is we're going to put
over here? Oh, it's just great.
we're going to put our restorative screws, and we're just going to use this nice torque wrench here. I've set it to 15, okay? And what I'm going to do is just go in here and torque our screws to 15. Let me see if I can figure out where my screw is actually located. There we go. So we go to 15.
Oh, that one is
Okay, hold on.
You can't speak yet, okay? Just a
Almost.
minute.
You're gonna show us our beautiful smile here in just a
Ah,
second.
Cut wires with layers, yeah.
It was up there, wasn't it?
No, we never had one.
Alright.
Is the normal thin?
Yep.
Oh.
Actually, you did know a lot about this stuff when we talked about it earlier.
Oh, yeah.
Yeah.
I'm giving you a
You are a
play.
mechanical guy. So there's a lot of different stuff you can fill these access holes with. We're just going to fill a little Teflon tape, awesome.
Yeah.
And then basically we'll use a little bit of impression material to film. Typically, maybe a week later, I might put in a material that is a sort of a light pure resin.
Is that pressure material with you?
Yeah, we'll go ahead. So typically, I'll have a cord packer here, but we're not going cord packer. I'm just going to use whatever instrument I have available. Oh, there we go. I don't know if you guys can see this. So basically, we're going to pack this in here. And like I said, any material that you want that's basically easily removable, but not so easily removable that it just comes falling out. Now, impression material actually works really well. You just have to be a little bit quick. Go ahead and open, Jimmy. So we stick this in here. You just kind of have to move quickly. Okay. And then you just wipe it off very quickly here, get all the excess. And if you don't do that, then it won't stay in the hole, it'll kind of drip out. Okay, so he's basically done at this point. You can see our incisal display is fairly nice. Go ahead and give us a big smile, Jimmy. Yeah, there you go. Got some nice teeth. Excited and ready to go. Now, Jimmy used to show no teeth at all in his smile, and now we got some chompers in there, so he's going to be really, really happy. Like I said, if the occlusion was so far off that I was really concerned, or when he bit down, it was just so far off, then I would adjust it more vigorously at the time of delivery. But right now, it's just off a tiny hair, so I'm going to do that on Monday.
We're good.
There you go. Look at you. Yeah?
We're good.
You look great.
I don't know if you can see the screen, but